Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
I am Tony Urbina, the Medical Director for CEI's HIV Primary Care and Prevention Center of Excellence. I'm a provider and professor of medicine at the Icahn School of Medicine at Mount Sinai, who has been working in the field of HIV for over 20 years. On June 18th, 2025, the FDA approved Yeztugo, the brand name for subcutaneous Lenacapavir, or Len, a prescription medication used for the pre-exposure prophylaxis of HIV. Subcutaneous Len is administered twice a year to reduce the risk of sexually acquired HIV infection in adults and adolescents at risk for HIV. With patients only needing Len twice a year for HIV prevention, the field has been optimistic about the potential for Len to reduce barriers and improve access to PrEP. Since we are still in the early rollout of sub-Q Len, many providers have questions about how to offer it to their patients, from workflow to billing to managing potential side effects, and importantly, drug interactions. On this episode, our guest is Dr. Alex Danforth. Alex Danforth is a clinical pharmacist in Rochester, New York. She practices at Trillium Health, a federally qualified health center, where she works with patients and providers to help manage medications and optimize care. Alex currently provides clinical leadership for HIV treatment and prevention programs. And Dr. Danforth has been a true leader in HIV prevention in New York State. She has worked on ahead-of-the-curve initiatives to improve access to PrEP. Dr. Danforth and I talked about the latest New York State clinical guidelines for PrEP, which were updated on October 16th of this year. The new guidelines provide important updates, including on subcutaneous Lenacapavir. We discussed important considerations for initiating patients on Len, as well as some early lessons learned from implementing Len in our clinics. While we are still in the early phase of actually rolling out Len, we are excited about continuing to improve access and learning best practices from fellow clinicians. I hope you enjoy listening to our conversation. Welcome, Alex. Thank you for joining us today. It's great to have you on. We know that the New York State Department of Health AIDS Institute clinical guidelines just recently published their PrEP to prevent HIV and promote sexual health in their HIVguidelines.org PEP and PrEP section. So I guess I just wanted to start by asking you, where is Lenacapavir in those guidelines and what's the latest data?
Thanks for having me, Tony. Yeah, so there's been a really nice update to the guidelines. And right now, they're calling out that subcutaneous Lenacapavir is approved for all sexual exposures in adults and adolescents who weigh at least 35 kilograms. There's a really nice table that goes through the key clinical and logistical factors that you might run into as a provider prescribing a PrEP regimen or talking with patients. There's also a bullet point there for it's currently being studied in the Purpose 4 trial for folks who use injection drugs, which is obviously a key patient population we want to be able to provide PrEP for, but don't always have a lot of data for, which is a great option for people. So in the guidelines, they really call out right now, we have a bunch of options for folks. We have oral options with tenofovir disoproxil fumarate and FTC, or tenofovir alafetamide with FTC. So those would be your two oral options. We have an intramuscular long-acting injection with cabotegravir, and then Lenacapavir, or Len, really provides a subcutaneous injection that's great for folks as well.
Yeah, I think you had mentioned before that I think there's an interesting table within the guidelines that kind of compares, I think for a lot of folks, like what are some of the differences like between the intramuscular cabotegravir and the subcutaneous Len? And I know that they have a table there comparing the two. Do you find that helpful, and what are some of your takeaways?
Yeah, I think having the comparison table is really helpful, particularly now that we have so many options, keeping them all straight in your head which ones are approved for which type of exposures. And then the main difference in my mind between the intramuscular injection is that injection is done every 2 months and it's a gluteal injection.
Yeah.
So there are some issues to consider there if people don't like the injection or something like that. Whereas the subcutaneous lenacapavir injection is done every 6 months. And that's a subcutaneous injection that you can do either in your abdomen or your thigh.
Yeah. Really interesting. And I think as like patients have more options, but providers are going to have to be more educated on all of these different options, just like you pointed out. So I always look to you and your clinic and your center for how you roll out and scale up, because I think you guys have been just so ahead of the curve in terms of really implementing long-acting injectables. So we don't have a lot of patients on Len right now. I think maybe we have 5. How many patients of yours have started on like lenacapavir so far?
Prevention, we have probably a similar number, like in the 4 to 5 range. We have a lot of folks who are interested. Our main challenge in really getting it rolled out to the patients in general widely has been like insurance coverage challenges. The good news is that, at least as far as we have a lot of folks who have New York State Medicaid, and right now it just got added to the pharmacy benefit formulary.
Saw that.
Well, so that is the like fresh off the press update, which should make patient access somewhat easier, because for clinics that don't have the ability to do the medical benefit billing or don't have the infrastructure for that, they'll at least be able to offer it to patients who have Medicaid that can get it under their pharmacy benefit.
Yeah, that's really exciting news and really right hot off the presses. So when you were thinking about rolling out lenacapavir, what's some of your current clinic workflow like for initiating patients?
We are trying to use a very similar workflow for all of our long-acting injectables, simply to, again, streamline processes and make it easiest for the providers. So if a patient comes in and talks to a provider about, and they want to have lenacapavir as a PrEP option, at least for now, we're also offering them something in the meantime. Like, would you be interested in oral PrEP until we can get your insurance coverage situated? Or if they're already on PrEP, we're having them continue whatever other option they're on until that point. But our general workflow is, after they talk to the provider, sends a note to our specialty pharmacy group that we have, which includes me and the other clinical pharmacists, along with some folks who work in our specialty pharmacy. And we start looking into, how can we get this medication covered? Does it go through the pharmacy? Does it go through the medical benefit? And then looking at, for folks with commercial insurance, like, what are the costs? Do we need to do a prior authorization? And then once we get that approved and we get the sort of all the complicated insurance pieces figured out, we call the patient and get them scheduled to come in for their first injection. We're fortunate that we have a specialty pharmacy on site, so they're able to manage kind of the inventory and make sure we have the oral tablets and everything to start the patient on lenacapavir.
Yeah, we have a similar kind of workflow and process as that. And I do think that the magic step, the secret sauce, is that benefits investigation. And I think what that team can do really to acquire the medication and make sure that patients don't get additional costs, because it is very expensive, right? The cost of lenacapavir. Yeah.
Yeah. For folks who might have cost sharing, there is some support from the manufacturer for copays and things like that, which is really helpful for all of the PrEP options. Really, there's something out there for them. I think part of it is also letting the patients know, because for a lot of them, they might not have ever been on a medication that's a specialty medication like this. And so managing their expectations, that it's not as easy as like, oh, I'm just going to send a quick prescription over to the pharmacy that you'll be able to pick up on your way out. It's not quite the same process, because it is physician administered, that we have to do in the office. So there's a little more layer. It was actually funny. So one of our specialty pharmacists made this little graphic that's an iceberg. So like the patient at the top, they're like, yes, I want a long acting injectable. And then the iceberg below the surface is all of this sort of behind the scenes work that the team is doing to figure out insurance and scheduling and follow-ups and all of those things. So it's not as quick and easy as when you want to give someone a blood pressure med or a diabetic med. You can just send it to the pharmacy and they pick it up later.
Yeah, no, I love that analogy because I think it's so true. So talk a little bit more about your workflow. So I know that for the loading, it's the injection plus the oral lead-in for day on 1 and day 2. Do you want to talk a little bit about your workflow for your second day oral loading and and then just ongoing management, and what if patient misses an appointment?
So what we've done is we've packaged up the oral loading tabs and basically rubber banded them to the Lenacapavir box that the injection comes in so that we can make sure we give patients the bottle to take home. So we elected to have the patient do direct observed therapy for their first 2 tablets with us in the office.
Yeah.
And then take the other 2 tablets home. And then we've been sending either, if your system has like capabilities, just electronically message like, hey, it's day 2, don't forget to take your dose. Or one of the nursing or front office staff has been calling to just check in and make sure they took that second dose. It's really important to make sure that patients don't double up and take all 4 of the loading tablets on the first day. You don't want to do that. And then what we know about the kinetic data and the modeling data is that if patients don't take that second oral dose, there really is a pretty significant several week delay in like time to protection. So having the patient understand how important that second oral dose is for getting the drug levels high enough to be protective right away.
Right. What do you typically think is the time frame for time to protection after that second oral loading? Because I've heard 2 hours, I've heard within 2 days. What are your thoughts about that?
So this is another place to call out that in the guidelines, there's a really nice section on what you can expect time to protection. And it has a really nice comparison between. So the time to protection is, at least what they call it in the guidelines, and I've heard this as well, is 2 hours after the second loading dose. So again, it's super important for patients to take that second loading dose because they really will be protected very shortly after that.
Yeah, no, that's important information. Now, what if a patient either has a planned interruption or if they want to discontinue? What's your upfront conversations about that?
We haven't, since it's so new, we haven't really run into anyone yet. Right? It's a very 6-month window or has something going on. But what we've done in the past with our other long-acting injections is try to, at the get-go, let people know, like, if you're going to miss your next scheduled injection for whatever reason, you're traveling, whatever, we need to know as soon as, so we can schedule it. The nice thing about the Lenacapavir long-acting injection is the official label is every 26 weeks, but you do have 2 weeks before and after.
Right.
So it gives you almost like a month of flexibility. So if you have a patient that's traveling or has some commitment that they're going to miss, you can do it up to 2 weeks early or 2 weeks late, if you will. So it gives you some flexibility. When you have patients who maybe have those unplanned missed injections that miss the appointment, getting a hold of them to get them rescheduled pretty quickly is an option. There's also some guidance in the Lenacapavir labeling on if your patient is going to completely miss the injection window, you can bridge them with oral Lenacapavir tablets taken once a week for up to 6 months. So that's another option that might, if you have someone who is going to miss entirely the window of opportunity to do the injection, you could do the oral bridge. Again, if they let you know beforehand and you can get that situated for them.
Yeah, that's important because if they do go outside of that window, you're saying that 2 weeks, then they have to be reloaded, right? So they have to start that whole kind of process again if they...
Yeah, correct. If they've gone outside the 28-week window, then you have to do the whole tablets, the loading dose and the initiation injection, just like you were doing it from scratch right from the beginning.
Yeah. And then if patients want to discontinue completely, let's say after that first injection, this is not for me, would you recommend switching to oral PrEP right away and just continuing for how long? What's your thoughts about that?
Yeah, so I think We've done a pretty good job as providers over the last few years, letting patients know that PrEP doesn't have to be a forever thing, that it can be episodic, it can be for the seasons of your life. But I think when patients want to discontinue, it's worth discussing, should we cover, do you need oral PrEP in the meantime? Like, are you still going to have some risk that you want to cover yourself with an oral option?
Yeah.
Because we do know with these long-acting injectables that, particularly for Len, after 6 months, the drug's really not working anymore. And then 12 months later is really when it's going to be out of your system. So you're going to have this window of time where if you're not covered by a different PrEP option, you could seroconvert and then have downstream effects later as far as medication options that might be available to you.
Great. Yeah, no, I think that's really sound advice. So shifting gears just a little bit. So you being the thought leader in this space and field, what are some of like the initial questions that you've been getting from providers regarding kind of lenacapavir? I think you had mentioned, I think one that had come up was just like switching patients, like either from oral or from IM cab. So if you could talk about that and just other things that have come up.
Yeah. So I think how to switch is always an interesting question because whenever there's a new option for anything that comes out on the market, it always seems like we have some patients who are already on PrEP who are like, ooh, that this new modality really appeals to me more than what I'm currently doing. So more than oral PrEP or more than long acting CAB or vice versa. And then you have other folks who are like, I tried another modality and it didn't work for me, or I knew I couldn't adhere to oral meds, so I never really got on PrEP. And so they're coming to you with no previous PrEP on board. So for our folks, what we've done is we've had some folks who have been on long-acting CAB who want to switch over to long-acting Len. And just for ease of all of that, we've timed it with whenever their next cabotegravir injection would be. You can switch right away in the middle of the 2-month dosing interval for the long-acting cabotegravir because the drugs are different molecules. So there's no reason why you couldn't start Len before the 2 months for the cabotegravir was up. But I think just for our workflows and making sense to us, we've said, okay, well, the next time you're due for a cabotegravir injection, if you want to switch to Len, we'll aim to have that ready for you to go at that appointment. And then our folks who are on oral PrEP and want to switch to lenacapavir, we've basically done the same workflow I described earlier, whereas we said, okay, you're going to stay on oral for now. And as soon as we get this insurance piece worked out, we'll call you and have you come back to start the Len. And we, in both cases, whether it's someone switching from oral to long-acting cabotegravir or like long-acting lenacapavir, we haven't really bridged, like done some people like to do the kind of the crossover.
Yeah.
Like, hey, take your oral PrEP, like while the long-acting injection's getting on board. If the patients feel very strongly they want to do that, we've said, okay, maybe you want to overlap for 2 days. But we've said, really, if you're switching, you probably don't need to do that and you can just switch right over.
Right. Yeah, no, I feel the same way. And how about like injection site reactions for the lenacapavir? I know that has come up. And so what's your kind of strategy or education or to that you discuss with patients or even providers?
Totally. I think it's really important to set patients up for success to help them understand what the injection site reaction is going to be like. Because for a lot of patients, they might not have ever had an injection like this. It's not the same as getting a vaccine, or even if they've been on long-acting CAB, it's not the same. Because what you have is in the sub-Q space, the drug's making this little depot, this little drug deposit that is going to dissolve and elute slowly over time. So it's very common in about 40 to 50% of patients that they're going to feel like a nodule or a bump under their skin. And that letting people know if you feel the bump, that's not out of the norm. But if you don't feel the bump, that's also not out of the norm. Also letting people know you may or may not get this nodule under your skin.
Right.
It may or may not be tender or red, just depending on how your body is reacting to this little drug depot that's forming. Another thing that really can help that we use in our clinic is like ice packs. So
Right.
pre-medicating, like having someone sit with an ice pack where you're going to do the injection for about 10 minutes beforehand and 10 minutes after. We usually just send the patients home with the ice pack so they can put it on as much as they want, does seem to help lessen the injection site reactions. And then same way as I would for anything else, just really don't be pushing on the nodules. Don't be trying to like massage them out. So those are all things we're trying to talk to about with the patients. And then two, it's good to consider working into your clinic flow. Like, is someone going to call and check in with the patient maybe a week later? Or are you going to send them a message like, hey, anecdotally, I've had patients tell me that when they did feel the nodules, they seemed to lessen, like as the days, weeks went on, like they get smaller and they really hardly feel them anymore. But then some people are very bothered by it and are just like, yes, I want this to go away as quickly as possible. So just letting the patients know.
Yeah, I think that's important. Like, yeah, setting them up for success. So I think that's really a great approach. I think it's been a great conversation so far. I wanted to talk to you now just like about the drug interactions. I think that's really come up a lot with lenacapavir. I think as you mentioned, we already have like lenacapavir for treatment.
Yeah.
For patients living with HIV. So I think we've experienced this a little bit, but I think now with lenacapavir for prevention, I think it's come up again. So do you want to highlight some of those drug interactions and how concerning are those interactions to you as a pharmacologist?
So what we know about lenacapavir as far as drug interactions is that lenacapavir itself is a cytochrome P450 384 substrate, but it's also a moderate inhibitor of that metabolic pathway. Yeah. And so there are some common drugs that go through 384 pathway. So most commonly things I see people worried about are like statins, so your cholesterol lowering medications, as well as erectile dysfunction drugs like PDE5 inhibitors. From my perspective, these are pretty easily managed drug interactions by starting at a low dose and titrating to effect. I have one reference I use pretty much on the daily basis is the University of Liverpool has a great interaction checker that you can use both an online web page version of, as well as there's a smartphone app that I use. They keep it really well updated, and the lenacapavir for PrEP is in there, along with all the other PrEP drugs. So you can put that in, and then you can put in all the co-medications a patient might be on and get a lot of good data and references on if there is a drug interaction, how you can manage or mitigate it, as well as like the references, case reports, things like that they have. And then if there's no drug interaction, they also tell you that too, which is really convenient. So that's a great reference for when you're thinking about how might Len for PrEP interact with other prescription drugs people are taking. And then if there's some kind of outline drugs that are also could cause the drug interactions. And for that, it's a little more complicated. And I would tell you to go to the label because there's some good guidance on the lenacapavir label about how to deal with if you have sort of more unusual drug interactions that come up. Another thing to think about, particularly when we're talking to patients, is how do we deal with drug interactions that occur not only with prescription drugs, but with recreational drugs. So I'm sure in your practice, Tony, you've seen some folks who engage in some chemsex or use recreational drugs who are also on PrEP.
Yeah, we do. We have for sure. And so I think my approach, similar to and I do love that HIV Liverpool interaction one. I just think it's so up to date. And I think about, my God, there just must be a lot of pharmacology nerds, which I love, that go into like updating this website, but it's just so good. And it's just really good because I think a lot of one's interactions, we're just not going to know. So I think I think that's a really great resource. I think exactly what you said. One of the ones that I highlight is like the opiates and fentanyl. I think until we know more, those could be potentially dangerous interactions. I also know with cocaine, there could be increases in levels. I think because of like the club drugs, specifically like methamphetamine and like ecstasy, because that undergoes CYP2D6 metabolism, that there may be less of a drug interaction there. So I think, and then I'm also really concerned with like GHB because it has such a narrow therapeutic index. And I know it also undergoes CYP3A4 metabolism. So that would be one that I would be very concerned about as well. So I think that those would be the ones that those are some of the things that I would discuss with patients. And then I think we spoke about this before, Alex. It's just that oftentimes like drugs are cut with fentanyl.
Yes.
So that I would really recommend fentanyl strips and really checking prior to use, because until we really have a handle on these drug interactions, that could be potentially dangerous and lead to bad outcomes.
Yeah, I think oftentimes, at least around us too, we've run into recently a lot of cocaine and other recreational drugs are cut with fentanyl. So having patients have an place where they can go. We happen to be lucky enough that we have like a harm reduction vending machine outside the clinic that can be accessed 24/7 that has like fentanyl test strips, Narcan, xylazine test strips, that kind of stuff in there that patients can access anytime they need it. But yes, we tell people always like test your drug supply. I think too, it'll be interesting to see what kind of data comes out of the Purpose 4 study that's exclusively looking at folks who use injection drugs, and how I think we'll get a lot of information from that about how the fentanyl and the opiates and other drugs people might be using potentially interact with the lenacapavir.
I'm very much looking forward to that data as well. So I think just a final question is, and I guess this isn't so much about long-acting injectable, but back to the guidelines, but what are the things from the guidelines do you think are important for our listeners to know? Or what do you feel were some of the additional highlights?
So I think some of the other key points was on the topic of like folks who use injection drugs. While the long-acting cabotegravir and TAF-FTC really haven't been approved or studied in those groups, they called out that they probably could be considered. So even though we really only have TDF-FTC as having the unofficial approved indication, it's nice that they called out like could be some other potential options for folks who use injection drugs. Additionally, in the Purpose 1 study, which is the one that brought lenacapavir for PrEP to market in cisgender women, there was also an arm that looked at TAF-FTC, using that oral option for folks who have exposures due to vaginal sex. And the study wasn't quite powered and all those things, but in the guidelines they call out, the data for that looks fine. So it's okay to consider for folks who maybe don't want or can't use TDF-FTC for vaginal exposures to consider using TAF-FTC for those folks, which I think is just nice because, again, you give patients who might have risk factors due to vaginal exposure more options to choose from.
Yeah, no, those are great points. So encourage everyone to read those guidelines. And Alex, thank you so much for joining me on the podcast. Your insights were really invaluable, and I know that our listeners will really benefit from your expertise. Really looking forward to our next conversation, and thank you again.
Yeah, thanks, Tommy. Thanks for having me.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.